Hey guys, welcome back to Painless Conversations. So glad to have you guys back again. It's been a good week for me, Chris. How's it been going for you? What's new?
Man, my week's been hectic as usual.
Yeah.
But I guess that's how life is nowadays.
Right.
Let's see, something new that I just got into more as fantasy football.
Oh, nice. Yeah, start of season is like this
Start of
week.
season's coming up. Exactly. So we like to do our drafts a little late, so just so we have all the information before going into football season.
Right.
The difference this year, I have to say, so I actually changed to be the commissioner of my league with my friends back home.
Okay.
So that's been a good change. I feel like for everyone who has done fantasy football, guys and girls, you guys know that people in your league, it's almost like a dysfunctional family.
Yeah. And this group of friends that you're doing the league with, this is like your childhood group of friends, right?
Childhood group of friends.
Back in Naperville?
Born and raised back in the dirty 630.
Yeah.
Naperville, Illinois.
630, baby.
So shout out to my boys, and I'm excited to see you guys in a couple of days on draft season. But yeah, it's like a dysfunctional family, man. You got your troublemakers. We're always looking to, finesse some people with their trades over the years.
Outrageous drafts. Outrageous trade proposals and so forth.
You know how it is.
Yeah, 100%.
You got like the newcomers into the league. You got the people who try really hard, like of all the mock drafts that may or may not be me, but still don't end up doing well. And then you got your people who don't, they might go on auto draft and they end up always winning the league.
I was going to say, it's the most unfortunate soul-crushing experience is when you don't make it into the playoffs, but the dude who auto-drafted from the start doesn't check his players every week. He's got someone on a bye week or something every week, missing a wide receiver, and somehow he makes it to the playoffs. That's soul-crushing.
I do not want you to complain about anything because you already know our family league. You were your first year in our family league.
Yeah.
You ended up winning the whole thing, even
That's
though
true.
You probably knew the least about football at that time.
That's actually very true, and I feel like I'm still like not that great with football, and like my knowledge of football is not great. I'm trying to work on it, but I do remember that year. That was like in middle school. Went off and won that whole trophy, bro.
There we go. Yeah, so there was a big trophy in that one, and so this time I'm commissioner in my league, and I'm trying to bring back some of that stuff too. So we're gonna buy a big trophy, get it, running along each year, ever rolling.
Yeah.
Get some plaques and stuff, and just make things exciting. So I'm super hyped.
Cash
for
awards too, or just the trophy for now?
There's got to be cash awards, bragging rights, and a nice little punishment at the end.
What is the punishment for the loser? You still brainstorming?
My friends are very, very creative, and so we have a poll of like 8 or 9 different things. One is, eat 10 blazing wings. One is paintball, where the loser has to wear a sign and everyone gets to shoot at them. Running a beer mile.
That's okay.
Which is a little change of pace.
Yeah.
So they got a lot of ideas. So we'll see which one comes out.
Okay.
Yeah.
It's cool though. Going back, I feel like it's nice that you. Through fantasy football, I feel like you're able to maintain that connection to people who are like started in April, but now they're on all different parts of the country. So it's awesome way to maintain a friendship group.
Absolutely.
So
tell me about you, Emil. What's been up?
Yeah. So
I heard you and Ashley have some big news to tell us.
It's
a little bit of a surprise, right?
We do have some big news. So it's been some time. We're a little late to this, but we've finally decided to bite the bullet and announce that we've started watching Game of Thrones. Thank you.
It's
a big milestone. So we just got through season 1. The first few episodes are a little slow, getting to know the characters. And I'm not going to lie to you, I like watching shows without subtitles, right? Because sometimes when you watch with the subtitles, like, you get too carried into the subtitles and you're not actually watching the show, right?
Yeah.
So it's like, no, let's watch without the subtitles so we can, like, be immersed into the whole show. And both of us are like, wait, what did he say? What did Tyrion say?
What did
Cersei say? Because it's English, but it just sounds a little different, right?
Yeah.
So it's hard to. So anyway, we went back to subtitles, but I will say, end of season 1.
Whoa, no spoilers.
Oh,
we don't need spoilers here, unless you want to spoil it for all the other maybe 2 people
holdouts
across the world who haven't watched.
yet. I think they'll be okay.
You and the previous owner of your 2010 Honda Accord.
Oh man,
probably the last person to watch.
You know what's funny? Probably around the time that car came out, was brand new, was when this show came out. So I'm on a roll here, guys. Like 2010s, like early 2010s. That's just me right now, all right? So, but on the real, end of season 1. Spoiler alert, I don't care. They got my boy Ned Stark, R.I.P. Ned Stark. the true protector of the realm. We'll see where this goes. I'll keep you guys updated, but it's starting to heat up. I like it. I think the hype is there. The hype was worth it so far.
You know what? To Ned and his family, just keep your head up high and keep going to work, you know?
Bro, win or fell or die, man. That's what I'm saying. True protectors of the North.
Well, I'm glad that you've officially, got into the grind of Game of Thrones. It's a marathon, man, not a race. So don't burn yourself out. There's too much to watch.
For sure.
Then you got House of Dragons afterwards. So
yeah. That's true. That's was a huge part of why I was like, oh, let's go watch the show. I heard House of Dragons is good too. So we're working our way forward to get backwards to House of Dragons. So, but Chris, I think it's time we get into the heart of the matter here.
What
do you think
jokes.
about that? We can do that. So cardiac anesthesia, that is a rotation that all anesthesia residents do out there at their training time. And Chris, we've had some crazy experiences on cardiac anesthesia independently. So I just wanted to hear about your experience at Harvard during your cardiac anesthesia rotation. Maybe you have any cool story or experiences you want to share.
Yeah, dude, like the best part about being over there is you have, just like the best of the best clinicians there. So because you have great surgeons, great clinicians, they also bring along great surgical cases.
For sure.
So you get to see like some of the rare stuff, some of the most complicated procedures, and that's a huge blessing for the anesthesia side too, because then we get to actually learn about these things from an anesthetic standpoint, how to take care of these patients.
Yeah.
But cardiac, as you know, Emil, in anesthesia, it's kind of like you take your training wheels off, you finish doing like the general surgery cases, and now you're starting to ride that bike on yourself. You're feeling pretty confident, and now, boom, cardiac anesthesia just hits you like a bus.
It takes it to the next level.
Yeah.
Right?
It's next level.
You aren't doing single IV general anesthesia anymore.
Yeah. So these are, for people back at home who may not really know the difference between just anesthesia for like a quote-unquote regular patient versus like a cardiac patient. And these cardiac patients, they don't have healthy hearts. And so a lot of the times you're, relieving obstruction from vessels that are going to the heart.
Yeah.
Fixing different valves that are connected to the different chambers of the heart, and even doing heart transplants or lung transplants. So it's a lot of physiology, learning how, almost like you were saying in the last couple episodes, like how the plumbing works.
Yeah.
And so lots of considerations you have to make from an anesthetic standpoint.
Yeah. I think this is like cardiac anesthesia, like you said, is truly where all of the beauty of anesthesia comes together.
Yeah.
I think I talked about how, like, when I was interested in medicine, I loved making analogies when I was teaching patients about hypertension or heart disease, like plumbing and using that as an analogy to hearts. And now I'm needing to use those same analogies to remember and understand that physiology so we can treat these patients well. So that's cool, man.
Yeah. So let me kind of get into it.
Yeah.
Again, man, this day felt like it was just yesterday.
Yeah.
So I'm in cardiac anesthesia. This is one of my last days on my rotation. And I'm a CA2, which means I'm in my second year of anesthesia training.
Yeah.
For lots of people in anesthesia, that's kind of like when you feel the most confident. You feel like you've seen everything and you can do everything, even though you haven't. And you don't know what you don't know yet.
Yeah.
But you're kind of a cowboy in some ways.
Was this the start of your CA2 year or?
Towards the end of my CA2 year.
Okay, so this is kind of towards that peak, like you're about to be a real senior CA3.
Exactly. You feel like a senior.
Yeah. Okay.
So feeling confident. It's like my last day of cardiac anesthesia, and I'm on what's called like a weekend call. Yeah. So basically, every couple of weekends, you go to the hospital and you work a shift where it's basically just you and you're an attending. Okay. And so there's a lot less resources in general.
Right. And so how long is this shift usually?
Shift is usually 24 hours.
Okay, it's 24. Same for us.
So a regular day
Hopkins,
for us.
It's also 24
Perfect.
hours. Yeah. Okay.
So, come in. And how this works is usually my attending is at home and like 30 minutes away or something. And so if there's a cardiac case that needs to go, the attending gets notified. They, roll in within 30 minutes and we get the case started.
Yeah.
Today was not the case. So what happened here was, I'm sitting in my call room.
Yeah.
All of a sudden I get a call saying, hey, there's this patient in the cardiac ICU. And they have what's called pacemaker leads that are sitting outside of the heart.
Okay.
So one of them accidentally got pulled off and created potentially a small hole going from the inside of the heart to the outside. and so that there could be some blood either surrounding the heart or just entirely leaking out of the heart.
So like a possible tamponade.
Tamponade
Like
versus rupture.
Okay.
So I get a call downstairs from the operating room saying that, hey, this case has to go down right now. And so it's not like your normal 30-minute emergency. It's like, hey, this patient's coming down stat. You need to be ready when we're there. And so I'm racing downstairs, and I give a call to the main operating room and see if there are any resources available for me because, as you know, it's an all hands on deck kind of situation. No senior there, no fellow. All of them are booked up. Yeah. Fortunately, there's an anesthesiologist who is able to supervise, to give me a little bit of relief. But I just remember walking down there thinking, all right, Chris, looks like we're going to put those CA2 cowboy boots on for a little test run.
Right. And so this is a really pivotal moment, right? Because as many times as we'd like to think, anesthesia is a solo sport. In reality, when you're in these trauma situations on call, when you're in cardiac surgery, when something emergent comes down, it's actually a team sport, right? It's all hands on deck. So, throwing it back to you, when it was one thing when you got the call, right? And now you're in the room, and now you're the newly minted senior that's going to be responsible for taking on these responsibilities and doing these procedures. How did that make you feel?
I'd be lying to you if I wasn't probably the most stressed that I've been in almost my entire life.
Yeah.
Like you have to have a certain amount of stress there because you got to know, you got to know what you don't know.
It would be weird not to have stress.
Exactly.
Yeah.
If I didn't have stress, like that would be super weird.
Yeah.
So I knew that, this is like a serious situation. And so I was mentally preparing, stressed out. But the funny thing is, I went into the chart. So I went down to the cardiac hours, went into the chart, and I saw that, this patient had lots of different lines or IVs set in place already and monitors. What we call like an arterial line, which checks blood pressure in real time. A central line that goes down someone's neck where you can give fluids and blood and medications really quickly.
To help with their blood pressure and so forth. So that's like a central line is basically like a big IV that goes, it can go in the neck, it can go in the groin and the big vessels.
So I'm like, yo, I'm set. This patient's all lined up. Just a little plug and play action. I'll be good to go.
Totally.
Patient
but
comes
that's
in the
almost
room.
never the case.
Exactly.
Something is going to go a little off.
Yeah.
I can already just smell it.
So that was kind of the climax of my happiness right there.
Okay.
Patient comes into the room, and as you'd expect, no monitors, no lines at all. Everything's been pulled out. Oh, so they had one 22 gauge, which is a very small IV that was running some blood.
22 running the blood. Classic,
right?
Yeah.
Yeah, can't expect anything less. It's not a story that we haven't heard before.
No.
But I guess they pulled out all those lines because this patient was doing so well.
Yeah.
Until this suddenly happened. So fair enough. So get down, and patient's very, very pale. It's very obvious that they're losing blood at a very fast rate. And she's still at least alert, oriented. So we get her onto the other bed, and here I am with this dinky IV. Blood pressure looks to be very stably unstable, I'd say. Tenuous, exactly. Yeah. And you kind of know that lots of things happen when you try to get someone to sleep, right? Their physiology changes.
Yes.
So didn't really have enough time to place extra monitors, but I did place a big IV just to make sure, if I had to run blood and such.
Yeah, it's your lifeline. You need something. Yeah.
So you know what? This is a matter of time. It's actually, they just need to get in and fix the problem, right?
Yes.
So push medication, some medication is a little different than propofol, but a little bit more what we call hemodynamically stable than propofol.
Yeah.
Push that. Give some other sedating medications. Blood pressure is dropping. Patient's asleep. At that point, I kind of freak out a little bit. Again, there's a lot of moving parts to this, right? Yeah. Push some more blood pressure medication. Go in to place the breathing tube in. Breathing tube goes in, and of course, patient gets blood pressure shoots through the roof now.
Naturally.
And I'm like, you know what? Not the worst problem to have. And so blood pressure goes up. Try to deal with that. Start giving some blood.
Yeah.
Surgeons quickly drape the field.
Yeah.
Everything's sterile. They place what's called a femoral A line, so a blood pressure monitor in the groin.
Oh, okay.
Pass that thing off to me.
Yes.
I catch it, hook it up. We have an extra monitor.
Yeah.
Patient's relatively stable. I'm placing like a central line in the neck.
You're doing you're tending, or you had no extra support yet at this point.
That's right. No extra. Well, we had an anesthesia tech.
Should have teched at least.
So that was nice. Kind of helps that with set up things. Super, super helpful. Shout out to all the techs out there who could not do without you guys.
For real.
You guys are lifesavers.
Genuinely, yeah.
So starting to put this central line in, and then all of a sudden I get a little tap on my shoulder,
Yeah.
kind of look back as I'm all like gowned in, and then I see my attending
A tap
by
on
me.
God.
He's like, "Looks like you don't need my help over here. I'm gonna be outside if you need me." And I was
What
like, "That's some badass stuff right there, bro." You know. And then after the surgery, everything gets finished. Patient's like stable. They figure out the problem.
Yeah.
Surgeon comes up to me. He's also one of my boys. We were like, together all month.
Totally.
And he knows who he is if you've seen this. Comes up to me, shakes my hand. He's like, "Brother, you're officially a certified anesthesiologist, man." And I just remember during that time, I was like, "It's wild, man. It was a long time coming." It was a nice feeling.
Pretty sure you did one of these. A
little
like,
mental. My hands were probably still sterile at that point.
A little shaky in the arms, but
exactly.
But that's wild. Do you feel like, speaking of the surgeons, in that moment, how was the communication between on your side of the drape and the surgical side of the drape with all this going on?
That is what I love so much about cardiac anesthesia.
Yeah.
And it's also every different hospital has their different cultures. But
totally.
In cardiac anesthesia and cardiac surgery in general, it's so important to keep that closed loop communication with the surgeon. It really feels like an orchestra. Like you're playing one side, they're playing the other side, and it's a back and forth communication. So I have to say the thing that made it the easiest is knowing that surgeon, one, that we were familiar with each other.
Yeah.
We had not only like just like a personal connection, but we've worked together professionally a couple times. So I know what he likes and he knows how much time I need. So it was great communication on both sides. Yeah. He was telling me what he was seeing. I was telling him how I was doing on my side and different lines or monitors that I was placing. And so it was a super efficient procedure. And I feel like, that's something that we really miss. I feel like sometimes in anesthesia, you feel like, oh, you're kind of by yourself. There's like this little split with this drape.
Yeah.
But the truth is, you're absolutely essential to the surgical team.
Right.
And the more you work together, man, it just makes things a million times easier. I'm sure you've had experiences like that, Mo.
And I was going to say, don't you feel like the days in the OR, not even necessarily cardiac anesthesia, where you are familiar with the circulator nurse, you're vibing with the surgical tech, the surgical side, attending, the resident, your anesthesia tech, everyone is just in a good mood.
Yeah.
Those are my favorite days and where I really enjoy anesthesia the most. I think I wrote in my anesthesia application, why do I want to go into anesthesiology? It's a team sport. And that's what I love about the OR environment, when everyone is on the same page and everyone wants to do what's right for the patient. But of course, on top of that, they're ready to back you up. They're able to see maybe you're struggling, and before you can even get to calling your attending or calling a tech, they're already calling a tech for you, or they somehow already got you a central line kit. That's the beauty of the OR. And I really like that analogy you said of the orchestra. Your two sides of it, and when it comes together, it creates this beautiful symphony.
Yeah.
So that's very cool. So, Chris, I had one more question just about the cardiac anesthesia side of things and generalizing that experience. Now as a chronic pain fellow, soon to be chronic pain attending, how do you see the skills that you learned during that cardiac anesthesia rotation, even that experience specifically, can apply to chronic pain? They seem like such disparate worlds, right? Like opposite ends of the spectrum, but I feel like there are some small overlaps that you can utilize as a chronic pain physician.
Dude, I love that you said that, because I feel like to the general anesthesia population in public, everyone feels like there's such a difference between cardiac anesthesia and chronic pain.
How many times is an attending...
Or anything anesthesia and chronic pain.
Yeah. How many times has an attending looked at you after you say, I'm going to chronic pain, kind of like...
Yeah, they kind of give you the side eye, like, okay, I see you,
we're doing a pump case, right? Yeah.
So it's so funny, because I always found that whenever someone asks me that, my answer is, man, there's so many similarities to cardiac anesthesia and pain.
Okay.
And it might not be what you're physically doing, but
sure,
the intangibles of what you're learning in each specialty is so important and so essential to both. And I think the two main things I would say is, one, you got to be a great communicator. So in cardiac anesthesia, you're in constant communication with the surgeons, and you're seeing what's happening on the other side of the drapes, and that's affecting your management on your side of the drapes.
Yeah.
And at the same time, You're taking feedback. You're also looking at like echoes and the function of the patient's heart, and they're monitoring, and you're coming up with clinical decisions to tell them and keep them in mind as well. So it's a very much a back and forth in cardiac anesthesia. And in pain, I think it's of utmost importance that you have to be a good communicator. It's almost essential.
Totally.
Not just for your patients, but also to your staff and colleagues and the other faculty around you.
Another
right?
team. Yeah.
Exactly. So I find that to be a super valuable trait. The other thing I think is just being a leader and a patient advocate. In cardiac anesthesia, there are a lot of things that we can see that sometimes aren't evident when you're just looking at the outside of the from the periphery of the surgical field.
Yeah.
And there are definitely times where sometimes you need to call the shots.
Yeah.
Or there are things happening that you need to tell the surgeon to stop or slow down or to look at some other part of what's happening in the surgical field.
Right.
And so that comes with being confident, being a leader, being a patient advocate. And so that's one thing I really respect about the cardiac anesthesiologists. They're badass.
Yeah.
And in the same way, when you're in the pain clinic, you have to be a leader and an advocate and a beacon of hope for your patients.
Totally.
Your patients are coming in there lost for a lot of the time because their pain is complex.
Yeah.
Their social situations, their psychological situations are complex. And so they're looking for you to lead them, to give them a clinical decision that's evidence-based, that's supported, and something that they are entrusting you to with their health.
Exactly.
And so you need to be a leader and an advocate in that sense too.
So Chris, I don't know if you remember this story, but I remember it very well. It was when you were a medical student back in Kansas City.
Yeah.
And you had called me kind of frustrated, a little sad that you were in a gyne surgery, like a gyne onc. Do you know what I'm talking about? Yeah, you were in the OR. This must have been like earlier, like one of your first kind of surgical rotations. And I guess you were in the OR and you were holding, as the med students do, retraction or the bladder blade, or you were holding the uterus or something up. And I guess they were running into some bleeding, and they were trying to find where the bleeding is. And I guess some of the bleeding was coming from the uterus, whatever. And I guess someone in the OR said to you, well, it's a good thing you're not going into a surgical profession.
Yeah, that's exactly right.
I don't know. I don't want to cut you off or paraphrase it, but that was the gist. And I remember when you told me that, being like, dude, who is anyone to say what you can or can't do? First of all, everyone's learning, right? No one is perfect from day one, right? Otherwise, we'd come out of the womb knowing how to ride a bicycle and knowing how to drive a stick shift car. But, but no, on the real, like, that was I feel like, that just reminded me of what you just said. From that to now starting a cardiac anesthesia, possible tamponade physiology case.
Yeah.
Big steps, my man. Like, that's big. That's big.
Yeah, I appreciate that. Actually, now that I think about it, man, that was like from that day until I did my cardiac case, it was probably a solid 6 years or so.
Yeah.
In between, and to I think just kind of prove the doubters wrong a little bit.
Yeah. Yeah.
Just feels good.
Yeah.
Using that as motivation, because I think that could have definitely set me back at that time.
Totally.
But the fact that you were there to just set things straight on the jump, and I was like, bro, what am I even thinking right now? I'm that guy, and you believe in me, and the medical society itself believes in me. That's why I'm here. That's why I'm doing what I'm doing.
Right.
To not allow that to get me down and for you to help me and just keep going, dude, it's crazy to think about how far we've come. It doesn't feel like a long time ago. So I appreciate you bringing that up, because now that I think about it, man, it feels surreal.
And I'm sure we're not the only ones that have gone through this.
Yeah.
You go through this medical training experience. I'm sure you guys can relate this too, where someone has told you can't do something, and in many ways, you got to block out the haters. You got to have a support, like Chris was saying. You got to have that support system around you that can be real with you, but at the same time support you and pull you up from your lows.
I was just gonna say one of the best things that I heard from one of my mentors is, don't let anyone else's dream become your dream. Right? So don't let what other people think that you should be doing influence what you want to do and the vision that you have for your own life. And I've taken that to heart from that day, actually, and I've never looked back since. So if there's anything I, hope to put out from today is like, just do your thing, man. Just do your thing. Keep pushing forward, and you can do anything. You really can if you put your mind to it, do anything. So, Emil, we had a pretty heavy conversation today, I would say, heavy on the heart.
Yeah.
So just to decrease that afterload and keep things light, I want to try something new that we have never tried on the show before.
Okay. What do you got?
It's called the compliment game.
Okay.
And so how it works is we're going to have to look each other in the eyes, and we're going to continue to go back and forth, giving each other genuine, sweet, truthful compliments.
Okay.
Until the other one laughs, and whoever laughs first loses.
Okay.
So, since you are the older brother, you should probably do the honors and start.
Compliments? Okay, so I start.
Should come pretty easy for you. I mean.
Yeah, for sure. I got them all written up right here on the back of my hand.
You had 28 years to think of at least one.
Okay. All right. Let's start. Hold up.
Bro, so
Let me do a little.
All right, give it the best you got.
Go.
Don't think too hard about it.
I'm not thinking hard. I already got it in my mind.
Why are you looking at my sideburns?
I really like how your earrings complement the shape of your ears.
Okay, bravo. If being sweet was an Olympic medal, you would win gold every single time. I think we have a winner, folks.
Is that left? If your eyes were as blue as the sky. Actually, I don't know where I'm going with that.
All right, boys. I think we're going to wrap it up from there. Well, we just want to give you guys a little bit of appreciation for joining in. And we really appreciate everything that you guys do for us, watching the podcast and supporting us. And Emil, if you have any closing remarks.
Yeah, and if you guys have any suggestions, stories, compliments, you're probably better at it than us, that you want to share with us, we're more than open ears for all of that.
That's right. And with that, I just want to say we hope you tune in for the next episode. We'll see you then.
Take care.